Hey everybody, it's Dr. Kadisha, your board certified emergency medicine physician and author of the best-selling book, Help Us Help You in the Emergency Room, is what an ER doctor would tell you if she only had the time. And I'm going to be joined for Eye Safety Month by Dr. Larry Ferdinand. Dr. Larry. Okay, so what I wanted to let you guys know before we get into the discussion is that my book signing will be Thursday, October 17th at the Melodrama Boutique from 5 p.m. to 8 p.m. Do check the post for the address. It's like in the 5800 block of Alameda Road. And all right, hi Patrick. Hi, Dr. Dietrich. Okay, so once Dr. Larry comes on, I'm going to bring him on camera. So guys, I just want you guys to put in the comments like any questions that you have about eyes this month. Okay, so we're going to talk about acute vision loss and less common, more less common, that's less common, more serious acute vision loss. And then we're going to talk about less serious, more common things. Okay, and so let me just bring Dr. Larry on. Okay, so let's see. Okay, and so let's see. Book signing in Baltimore. I have to work on that. So yeah, I'll need to, hopefully I can do something like that before the end of the year, and or maybe the beginning of next year. Okay, so let's see. But yeah, hopefully I can do something. I'm hoping to do something in DC, hopefully, but also before the end of the year. And let's see, let's find Dr. Larry. And let's see. All right, let me bring him on. Bad friends. Okay, let's see. So yeah, folks who are watching, put your, while I get set up, while I bring Dr. Larry on, please put your questions, comments, or concerns regarding eye safety in the chat. Let's see. Just a second. Okay, hey Dr. Sylvia, thanks for joining. And yeah, please put some comments in the chat here while we get started. Okay, so hey there. Okay. Okay, let's see. And who else? Okay, so in the meantime, while I try to bring up Dr. Larry, I'm going to bring up Dr. Dietrich. If you can, are you willing to come on camera? Okay, so yeah, guys, please. So yeah, we're having a few technical difficulties here, but yeah, please definitely put your questions or comments in the chat. That's fine, Dr. Dietrich. If you're not willing, if you're not ready to come on camera, that's fine. I just yeah, we just want to make sure that you guys get to have your questions answered. Okay, so let's see here. Okay, all right, so I'm going back to, let's see, going back to my main page and see here. Okay, so yeah, trying to invite him into the chat. Hey, Dr. Ashley. Okay, hey, Doctor. So, Dr. Dietrich, does that mean okay? So, Dr. Dietrich can come on camera while we bring. Okay, thank you, Dr. Larry. Here we go. Okay, we are adding Dr. Larry. Hey, Dr. Larry, good evening.
Hey, good evening. How you doing?
Good. I'm good. I'm better now that we got you. Now that we got you on the live. It's been long time no see, long time no hear. So I decided this would be a great time to bring you on for eye care and eye injury prevention month. And because as an ER doctor, I have to admit, I hate eyes. They're amongst the most important organs in our body, and they're so small, and there's not that much that ER doctors can do for the eyes. So, and then, of course, with the ERs, of course, we refer people for follow up, but we never know if they do. So, I really wanted to bring you on to hear what your concerns were as an eye specialist and to hear about what happens with follow up and why it is so, so, so very important for people to follow up after being in the ER. Even though we might get you feeling better, even though we might get you feeling like you're back to normal, it's still important that you follow up with the eye specialist. So, I'll just
Absolutely.
talk about, thank you, thank you. So yeah, Dr. Larry, so I'll just let you know that, some of the more common things that we see in the ER are, corneal abrasions, foreign bodies, conjunctivitis, things like that. They're not terribly serious, but they're terribly common and they can affect eyesight. And so, but once we put that tetracaine in the eye and the person feels better, then and we give them their antibiotics, we may or may not get the foreign body out. We refer them to follow up, but I don't think a lot of people follow up just because they're feeling better already. Now, one thing I want to ask first thing is because the patients love the tetracaine. They love those tetracaine
Don't give it to
IV.
them. Do not give it to
Why?
them. Please
Okay,
do not give them
tell the public.
tetracaine.
All right, right.
All
And
right.
I tell them that we can't give it. Like they want to take that stuff home. Tell our watchers why we cannot give the tetracaine for them to take home.
Well, tetracaine, let me just say this. I appreciate all the ER doctors that say no to tetracaine for the patient. Keep it in your clinics, even put it in your pockets, just so they don't pick it up and take it with them as they go home.
Yeah, I
Uh,
do take it. I put it in my pocket when I walk out of the
yeah,
room.
it's
And I'm sorry, I'm being awfully rude here, Dr. Larry. Please introduce yourself to us formally
yes.
before we get started.
I am Dr. Larry, IMD, board certified ophthalmologist. I am vision health expert through books, talks, and conferences. I help people and corporations improve their eye safety and job environment to inspire their workers in and also promote eye safety on the job. So, like I said, with Tetracaine, oh yeah, you can follow me social media at Dr. Larry, Facebook, Instagram, Twitter. I'm on that. But like I was saying with Tetracaine, it's what it is. It's just it's a anesthetic, and your cornea is a very sensitive part of your body. Probably the cornea has more nerve endings per square centimeter than any other place in the body. So if you get a scratch or abrasion, it feels like holy hell has unleashed on your eye, and you needs to do something about it. And that makes it, people want to have tetracaine because it's immediate. You get that anesthetic feeling, you feel better, like, oh my God, I can open up my eye now. I can actually, do an exam for you to check my eye. But guess what? That wears off in like 10, 15 minutes, and you're right back where you started from. The problem is with tetracaine is that being that it's an anesthetic, it will numb the eye, but it also causes nerve damage. Okay.
Okay.
The reason why you get that numbing feeling is because that drop basically dysfunction the nerves that's kind of like firing off, telling you, hey, I got an abrasion, is basically that if you take too many of those drops on a consistent basis, you just basically kill the nerve endings in the cornea. And when you kill the nerve endings in the cornea can't respond to different things like dryness, lack of moisture, if you have any other abrasions, and it also can cause a bad ulcer on the cornea.
Okay.
Bad ulcers on the cornea are very hard to heal, especially if you kill the nerves there. And when you kill the nerves and the cornea can't heal, that means that you're going to end up needing a corneal transplant, or you're going to lose vision, and you're not going to be able to see out that eye.
Got it. So, people, so that is why we're not being mean. The ER doctors are not being
It will
mean
create a
by,
more irreversible problem that will lead to more serious consequences if you get that bottle of tetracaine or proparacaine.
thank you so much. So, okay, so now that we got past the tetracaine dilemma, okay, so people, please stop hating us for not letting you go home with the tetracaine. So, okay, so among the most common things that people come in for with regarding eye complaints is corneal abrasions. And I remember when I was in medical school, I actually did have a corneal abrasion, and you're quite right. It hurt like holy hell to the point where they just sent me home. And I still don't know what it was that caused the abrasion, because sometimes it could be as little as your own eyelash getting in there. But back then, when I was sent home with an eye patch, why aren't we using eye patches anymore? Because people also are, they're a little bit inquisitive as to why I'm not sending them home with eye patches anymore.
Uh, well, just depends on how big the abrasion is. If you have a large
Okay.
abrasion, yeah, I would patch it. What I usually do with people with large abrasions that's like over 2 millimeters, I just one, which is probably more comfortable with people, I put them in like a bandaged contact lens. Now, this is a contact lens that goes in the eye. You don't have to take it out. You don't have to put it in. It just stays in your eye until that abrasion heals up. The benefit of the
Okay.
contact lens is that you can still pretty much see. You don't wear a patch over your eyes, so you still have the function of that eye, but it covers the abrasion. So the reason why abrasions hurt is because when you blink, the eyelid will kind of graze over that area. And like I
Got
said,
it.
the cornea is more the most innervated, most nerve endings in the cornea. So as you blink or you bat your eye, it rubs up against that abrasion, and you're going to immediately feel it. So the contact lens acts as a barrier from your eyelid from blinking, so it protects that abrasion, so it gives it time to heal, and you can still do the things that you need to do. Now, the other thing is just patching the eye. What I usually do is get antibiotic ointment, goop it up in the
Mm-hmm.
eye. I usually pull that eyelid down and just really just layer it up and tell the patient to close their eye, and I put an eye patch on there, and I call it a pressure patch, where I put a lot of tape to where the patient can't open their eye or close it. It's just on there. They keep their eye closed. They wear it overnight. I usually don't tell people to wear it over 24 hours, but usually it doesn't take that long for corneal abrasions to heal. So during that time, you keep your eye closed, the ointment's in there. It give time for the abrasion to heal up. And usually, if it's over 2 millimeters, that usually heals up pretty quick, between 24 to 48 hours. But the contact
Okay.
lens, I can send people home for like 3, 4 days with the contact lens. As long as they don't rub their eye too much, then they usually are very comfortable while they're healing. And when they come back, the cornea is perfect. So, I mean, with those type, if you have a big abrasion there, patching or contact lens, send them home with it. I can sleep at night. But if it's less, if it's a small abrasion, I could just usually put some ointment in it and just say, hey, you use this ointment about 4 times a day, especially before you go to bed at night. And by the time
Okay.
they wake up in the morning, it's better.
So let me ask you this, at least another burning question. For how many days is it recommended that people use those antibiotic eye drops or the ointment?
Um, I usually put people. I mean, it's okay to put people on antibiotic drops for at least 7 to 14 days. Usually, if it's abrasion, if I'm as long as they have the contact lens on or the bandage contact lens on, I put them on some antibiotic drops. That in itself helps people not develop ulcers while they have the contact lens in. I mean, you shouldn't be developing ulcers if you never wear contact lenses before. But
Mm-hmm.
sometimes people get in some crazy stuff and do some crazy things. So look, I'm just giving you some antibiotic ointment so I can go to sleep at night. But typically, I usually put people on an ointment or antibiotic for at least a week, maybe 2 weeks, depending on how bad it is, and they usually do
Mm-hmm.
pretty good.
So, and that leads me to ask this question because, I'm talking, from the point of view of a person or a physician who starts the person on the antibiotics. So, I'm writing for, I'm saying, take these, or insert these eye drops or the ointment, as directed for 5 to 7 days. And, um, we're not saying that that's to be the entirety of your treatment. That's supposed to be at least until you can follow up with an eye specialist like Dr. Larry. We are not supposed to be in the ER giving you the entire treatment for your
Right.
eye condition or injury. That's why we also say in the discharge instructions, and please read those, uh, that you should see the eye specialist like in we say like maybe 2 or 3 days, if that's okay, Dr. Larry, 2 or 3 days, and then Dr. Larry and Dr.
If
Larry will
you
take it
if you
from
see a
there.
patient on Saturday or Sunday, I'm expecting that
Yes,
patient to be in my office on Monday. Uh,
God.
just I mean, I appreciate the ER doctors. They allow me to enjoy my weekends and allow me to sleep at night. So I'm always thankful for them. But as a way that I appreciate what they do, I want to see the patient as soon as they can get up on Monday morning and get to my office.
Okay.
I mean, even if it's abrasion, even if they have a patch or whatever's going on, I want to see it just so I can say, "Hey, you'll be fine. Keep kicking," or "Hey, we need to get you on this treatment plan." A small abrasion can turn into something big if you don't follow up. And that's typically, it can turn into an ulcer, it can turn into a corneal melt. or you can develop
What's a
inflammation.
corneal melt? Wait a minute. Wait up. Hold up. Hold up. What is a corneal melt? That's a new term. That's a new term to me now.
Corneal melt is basically the cornea is made out of collagens, and sometimes you can get a bad bug in there that loves to eat that collagen, and like
Ooh.
Pseudomonas, not really like staph infections, but definitely Pseudomonas is one of the more aggressive um, bacteria out there. They just gnaw at the cornea, and
Mhm.
like
And
within
is it
like a
true
day
that
or two.
and is it true that people who wear contact lenses that they're more vulnerable to Pseudomonas, or are we all equally vulnerable? Okay.
Contact lens wearers are. I love y'all, but y'all the worst. Y'all the worst people in the world for ophthalmologists because y'all can sit up there and be like, "Oh, I can see, my optometrist put me in these wonderful contact lenses, and now I want to jump in the hot tub and kick it with my boo." Never ever go into any kind of swimming pool or hot tub with your contact lenses. Please take them out
Ooh.
because usually, you don't know, especially if it's not your pool or it's not your place where you go swimming or do any water activities, especially if you go to lakes, you can get bad things like a canthamoeba, which is not exactly a bacteria. It's what we call a protozoa or a living organism that can embed into your eye, lay eggs, and create other bad, things that can eat up the cornea. And like I said, the cornea is a very innervated part of your body. So anything in it or disturbing is natural, lovely beauty is going to make you make a living hell for you. So
Okay, so let me stop here since Dr. Larry's talking some serious science here. He's even blowing the doctor's minds up in the chat. Can you guys please share this, like, comment, share this with your friends who are lay people. We're preaching to the choir here, but we definitely need to have like our friends and family hearing this information because if they don't get this information, they're going to be coming to the ER doctors, the family doctors, and
and they don't want to
we're going to
see
be like,
it. Close it. it, it's too nasty. You know what they gonna do? They be like, glad it ain't mine.
Right, and then we're gonna be all, on pins and needles because that's when y'all come, when you're in the hot tub during the weekend, you're mowing the lawn with no glasses on, using harsh cleaners and detergents and stuff on the weekend when Dr. Larry is not in the office, and then you come into the ER. So we really need people, as many people as possible to hear this message. So keep going, Dr. Larry.
Yeah. So, I advise people with contact lenses, please take them out before you do any water sports. Okay.
Okay.
Um, I, I, I mean, if you that blind that you need your contact lenses during water sports,
See, that's
then,
what I was thinking. That they need to they
like we
would need
need
to
to get
see.
you in with a refractive specialist, so or get you a good pair of goggles, so you can go
Okay.
play in the water as much as you want. And we can make prescription goggles. There are prescription goggles out there for sports or any activities. But yeah, if you go on, the thing is the Pseudomonas and all those bad things, they like to, swim around in water, especially water that's not treated. And with contact lenses is over your cornea. So if anything
Mm-hmm.
kind of creeps up under there, it just kind of the cornea is kind of walled off from the rest. It doesn't have a consistent, especially if it's soft contact lenses, which most
Mm-hmm.
people wear now. It kind of traps the tear film under it. So basically, it creates a good environment for bad stuff to grow because it's not washing away. It's not blown away with the air or not getting recycled out
Yeah.
with the normal tear film. So all that can get into the cornea, just create a mess.
Got it. So that is why people who wear contact lenses are more vulnerable to bacterial infections.
Right.
Wow.
And
Really good to hear.
take
Mm-hmm.
your contact lenses out at night. Don't sleep in your contacts. I know people tell you, but there's always that rogue optometrist out there that says, oh, you can wear contact lenses for a month and not have to take them out because they don't have to deal with it. Now, no hate on my optometrist friend, but don't be putting these people in contacts, telling them they can live their life freely, fancy free, when you know you ain't got to deal with the consequences and repercussions. They come see me. They don't go see you. They come see me. So, yeah, please take your
So,
contact lenses out. Good solution. Keep your solutions up to date, case and everything.
okay. Okay, and so yeah, how long can someone go without removing or changing their Are you just saying like every night, just take them out every night?
Yes. Yes, I
Okay.
am.
So even those extended wear,
It's
what's
no
up with
such
the
thing.
extended?
It's for you to
Okay,
buy
so that's
them. Extended wear is for you to buy them and think you can get away with it, but you can't.
okay. So
Some
all right,
people
so
who think
mine
they get
will.
away, some people, they come in, oh yeah, I sleep in my contacts all the time and I don't have a problem. Be the same person next month, be in the office like, yeah, I've been sleeping in my contacts and my eyes red and it's very hurting. Oh, you got about
Okay.
4 or 5 ulcers on your eye. I wonder why. So
And okay, so if someone comes into the
don't
ER
make it a
with those
habit
ulcers,
of sleeping in your contacts.
okay. All right, and so if someone does come into the ER with these ulcers on their eyes, um, what do you want ER doctors to know about these, contact lens
All right.
associated ulcers?
Contact lens wearers, if they, I mean, which I usually do, y'all check the vision and y'all get the fluorescein out and y'all stain it. And if it's like a little small little pickup when you shine the blue light on it, or is maybe on the side, maybe a little bit in the central, just what I usually tell them is just start them on like an antibiotic drop, like Vigamox,
Okay.
Ocuflox, and it's just every hour on the hour. Like
Okay.
while you're awake until you come see me.
Well, okay. While you're awake, so it's not like you have to wake up every hour from sleep to
Well,
put the
well,
drops in.
if you haven't
Okay.
seen me and I don't see it, you put that drop in every hour on the hour. Wait, throughout the night. You know, you see me and I look at it and I was like, okay, you can do it every hour and an hour while awake, and I can put you on some ointment at nighttime. So when you go to sleep, you have a little coverage there, then you'll be okay. But if you're in the ER doc, you tell them, take this drop, Vigamox, Ocuflox. I usually don't put people on Cipro, but those are
Oh.
Cipro is like first generation fluoroquinolone. You're talking about like fourth and
Hmm.
third. But fourth and third generation fluoroquinolones every hour while awake, and also during the night, you need to put that drop in
Okay.
until you see me. And do not
Okay.
put that contact lens back in your eye. A lot of
All right.
people don't say that, don't tell people that, because the next day they
Okay.
may be feeling better and they're like, oh, boom. No, until you see an eye doctor to tell you, okay, you can put the contact lens back in your eye, that's when you do it. Do not go back in that contact
Okay.
lens.
Okay. So really good to know. I will review the discharge instructions at my ER to see if it says that, and I will write that in specifically, like in the custom instructions. Do not put your contact lenses in until, and I think usually I do that, but it's just good to hear you say that. Now, Dr. Dietrich has a question. She asks, how long can the contacts stay in the little container after you've worn them?
Uh,
Oh,
Typically, I say if you wear contacts and you put them in a container, and let's say you don't wear them the next day or the day after that, uh, typically if you don't have if you usually people keep them in solution, so it keeps that, keeps them disinfecting. But if you haven't wore your contact lenses in like a week or two, and the thing is dry, you may not want to put it back in your eye. You may want to start fresh with a new contact lens, and then put it in solution, clean it, you know, and then put it in your eye, and that'll be better. But I say probably I wouldn't leave it in the case without at least recycling the solution for more than 2 weeks if you don't wear them all the time.
okay. Okay, so Dr. Dietrich, I hope that answers your question. She says, "Oh, okay." So see, Dr. Larry's teaching the doctors and the patients up in here. So I knew I needed to bring you in here. So
A lot of
whew.
contact lens wearers out there. I know.
Okay, and since uh-huh. Okay, and so another burning question. All right, so I'm down here in Houston. Dr. Larry, you're in where, Mandeville,
Covington,
Louisiana?
Covington, Louisiana,
What?
but Mandeville is like 5-10 minutes away from me. Well, 10 minutes away.
Okay. Okay, now in Houston, there's a lot of plants and things here. I don't know about where you are, but we have a lot of people who are doing welding and or just what machinery work. And it surprises me that these gentlemen, usually it's gentlemen, there might be some ladies out there who aren't wearing goggles and they're still coming in with metallic foreign bodies. And we get in there in the ER with that bird drill and we might get pieces of it out.
Hmm.
Um, but what if we don't get it all out? What if we can't get it all out?
Send them
Do we
to
need to send them to you?
Yes, because what happens, especially if they've been grinding on metal against metal, or if it's any kind of foreign body. Some foreign bodies are, the cornea can handle, but metal is not one of them because metal
Okay.
oxidizes and leaves rust, and rust is can be painful or toxic for the cornea. Uh,
Mm-hmm.
Most ER docs are good with getting a lot of that stuff out, but if you don't have a burr or you don't feel comfortable taking that metal out, the patient's not going to die if they don't see an ophthalmologist in the emergency room at that point in time. But, I usually would say, put that patient on some ointment, put the ointment in the eye that can make it soothe it a little bit, and then have them
Mm-hmm.
see us the next day or the next available time, and we can take a look and we can take that out. Typically, with metal that's embedded in the cornea, it's just localized irritation, localized abrasion, and usually within 1 or 2 days that's removed. We can take it out, and then it's just once we take it out, and we do use a burr. Use a burr to make sure we get much of that rust ring out as possible if it's metal. And usually, I may use a bandage contact lens or eye patch, and within 24 48 hours, those patients are good. So it's good to follow it with a eye doc. If you, as an ER doctor, feel like you haven't gotten all the stuff out, or you still see a lot of rust around that area where that metal is, make sure you have that patient follow up with an ophthalmologist so they can get the rest of that out.
Okay, and for sure we're gonna send them to you, but this stuff happens per Murphy's Law, it's Friday evening after, just after you guys have closed,
Yeah.
and it's like, oh God, we gotta have these people wait like 3 days
They'll,
to follow up.
they'll be fine.
Okay.
They'll be fine.
Thank you. And then,
I've seen people walk in with metal in their eye for like 2 weeks. Like, it's just keep on bothering me. I don't know. I think I got something in there, and it's just sitting there. And all I do
okay.
is just, take it out, bury it, and they heal just like everybody else. But the
Okay.
politically correct
Fantastic.
thing is to say, see your eye doctor as soon as possible when
Oh,
when you
yeah.
can see them. So whenever you guys, see them, make sure you just set it up. Just put them on some ointment. Just say it's just soothe it until you're able to see follow up in a clinic.
Okay. Gotcha. And am I getting the impression that you prefer ointment to eye drops?
Yes. Well, I mean, it's ointment is a great thing because what it is you just want, some kind of barrier in between the place that's affected on the eye from that eyelid. And whether it's a contact lens or ointment to help that lid kind of slide over that area,
Mm-hmm.
it's always more comfortable for the patient. It's not perfect,
Okay.
but most of the times I put people on ointment, they do pretty good. I really don't
Okay.
see, I mean, with anything, the first night may be the roughest night, whether I put anything on it. But, after that, they do good.
Okay, awesome. And then now to uh, another topic that's a little bit nasty, but we're in the season for, we're entering upper respiratory infection season, virus season, school's back in conjunctivitis.
Oh, yeah.
Conjunctivitis.
I mean, just to
Viral
give
versus
credit.
bacterial. And are we wrong to provide antibiotic drops even if we think it's a virus? Is that so wrong?
Uh, I mean, I would say, decrease it. I mean, you
Okay.
don't need to throw antibiotics at everything. I mean, what conjunctivitis is just a cold of the eye. It's an eye cold.
Okay.
When you get a cold at home, it's just a virus that just has to eventually work its way out of your body. You build up immune system
Okay.
for it, and as soon as you build up immunity for it, it goes away. And that's usually with viral conjunctivitis or, well, viral conjunctivitis, which is the most common cause of pink eye. Now,
Got
bacterial
it.
conjunctivitis, it can happen, but usually it's more in an adult and not so much a child. It's usually more of a
Okay.
hygiene problem. So if somebody comes in with bacterial conjunctivitis, that's like over 18, I would like
Mm-hmm.
say, hey, let's do some lid scrubs with some baby shampoo, some artificial tears, preservative free that you can take 3 or 4 times a day. But make sure, going back to the ointment, you can put some ointment in at nighttime to help decrease the bacteria load. And that usually, helps with resolving the problem of bacterial conjunctivitis. Usually, antibiotics probably can be used less if, somebody that's of, adult age that comes in with a pink eye. I wouldn't jump to the antibiotics. I understand like antibiotics, hey, it still could be bacterial, so I could
Mm-hmm.
be justified with giving them an antibiotic. But more likely it's a viral thing. I usually when somebody comes in with a pink eye or pink eye presentation, I'm like, do you have any sick contacts? Oh yeah, my child's in daycare. They had pink eye, and then I'm holding them or I'm babysitting them,
Yeah.
and boom, I got it.
Yeah.
Wash your hands, carry around hand sanitizer, change your linens, um, artificial tears, preservative free, uh, probably like a over the counter allergy drop. And,
Mm-hmm.
you just have to, suffer through it for a little bit. But the most important thing is hygiene, so it doesn't circulate back around the house because it's a virus. You know, sometimes when people get better, if somebody gets it, they can reinfect the person that just got better, and then it just, flip flops. So that's the important thing.
Hmm. Okay, so burning question about this then. When and this might address Dr. Ashley's question, and then Dr. Tanya, I will get to your question about the makeup because that's a great question. Um, how long do we tell parents to keep their kids out of school once, we diagnose them with pink eye? And how
Uh,
long do they need to be on the eye drops before they can safely return to school? If you can enlighten us on that.
Usually, the window for pink eye is it's contagious in the first 7 to 10 days of somebody having it. So it's good to probably keep them out of school for at least a week. Um,
Ooh.
if you, yeah, if it's an adult, then I could be like, hey, carry some hand sanitizer. Be careful where you touch. If you touch things, carry a paper towel so you don't circulated. But if it's a kid, you can't really, you know, be so controlling over the kid because they're gonna do what they want to do when they want to do it. So it's probably
Mm-hmm.
if a kid has a definitive case of viral conjunctivitis like pink eye, probably weak. A doctor write the note excuse, and I know you got to find people who look after them, and got to find a babysitter. It's a pain. So be careful out there. Don't take anything for granted. Wipe down the grocery cart. Take that wipe. If you're in a public
Yeah.
bathroom, get that, paper towel, pull the door open, toilet, pad it up.
Right.
Just take
Right.
the extra precautions because you don't want to. I mean, it just is what it is. You're just gonna have to deal with it. And good thing is it'll eventually go away, and it doesn't affect the
Mm-hmm.
vision too much. Um,
Mm-hmm.
but it just some things just happen.
Got it. And so, and that's another good reminder. So people, wipe down the toilet handles, the microwave door handles, the doorknobs, the remote controls, the PlayStation,
Safe
whatever you
sex.
call them. Huh?
Safe
What
sex.
you say?
Remember to practice safe sex.
No. Okay, yeah, I guess okay, yeah, because hands can go in the eyes and they can go everywhere. Okay, even in that situation.
Well,
Okay. Okay, gotcha. So
well, I just passed by that.
okay.
It's a G-rated
Um,
Facebook Live for all y'all.
yeah, this is a family friendly Facebook Live.
Yeah.
Family friendly Facebook Live. Okay, oh, so Dr. Ashley is leaving. She's
Hey,
bidding
Dr.
us
Ashley, I
goodnight.
got my shirt. Mm.
Oh yeah, I
Mm.
got my shirt too, Dr. Ashley. I got my shirt too.
Thank you.
Yeah, thanks, Dr. Ashley. Okay, so all right, so with conjunctivitis, most likely it's viral. Say you got the green, yellow discharge coming from the eye. Is it still most likely viral, or can you, with more certainty, say that it could be bacterial?
That's the whole thing with conjunctivitis. It really could be either or because they kind of present the same unless you like actually get behind a slit lamp to kind of see the signs of what may be more viral
Mm-hmm.
and what would be more allergy or bacterial. I mean, just like I said, you're not exactly in the wrong for putting people on like antibiotic drops because they all kind of present the same. It's just little quirks. Like usually with pink eye, you may have like little swollen lymph node or preauricular lymph nodes that um,
Really? Okay.
I
Mm-hmm.
usually like, rub the preauricular area. Usually, if they have like swollen lymph nodes, that's more of a viral conjunctivitis. If it's just kind of goopy. If it's really goopy, like if they have
Yeah.
strands of like pus, like then that's bacteria. Get them on the antibiotic drops. If it's and a lot of times when people have upper respiratory tract infections, they can have more mucusy discharge, and that's more so like controlling kind of like the symptoms of the upper respiratory tract infection. So
Mm-hmm.
give them some oral antibiotics along with some eye drops would be valid. Allergic
Okay.
conjunctivitis, key thing is people have a history of um, seasonal allergies, dark rings around the eye, uh,
Yeah.
people that usually get eczema and stuff. Those are more reasons for allergic conjunctivitis. So I'm putting the people on antihistamine drops, maybe some.
And histamine drops like what? Because we are docs. We kind of stay. We focused on the infections and things
Mhm.
like that. Are you saying that folks could actually get, and can we in the ER prescribe these antihistamine
Oh
eye
yeah,
drops?
oh yeah.
And can you name a couple? Can you name a couple types of those eye drops?
My go-to, well, the key one usually people use Patnol or Pataday, Zatador, which you can get over the counter now.
Okay.
Alloway, you can get over the counter. Optivar is a prescription. I think you can get that over the counter. The good ones I usually present, but for some reason, like you run into a lot of insurance. I mean, insurance company denials when you get up to real big gun allergy drop medicines like Pataday and Pazeo.
Okay.
Then insurance company like, why are you prescribing this? This is I don't know if we want to pay for this. So usually the over the
So
counter
the basic.
Zatador,
Hmm.
Patnol, Alloway
Okay.
are they do pretty good.
Okay, awesome. Oh, and Dr. Tanya Lowe is reminding me about the makeup and eyelash application question because, a lot of us, a lot of your classmates, Dr. Larry, like myself and others, you guys are lucky. The guys are lucky, but when we do these events, we have to get makeup artists and they're just going from person to person to person using the same brushes and just every, makeup and stuff like that. What do you have to say to the late, and I mean, and men get makeup too. So, what do you have to say about the makeup and eyelash application?
Okay,
Uh,
I say as an ophthalmologist, I say less is always better. But
uh-huh.
I know they have some cosmetics out there that are hypoallergenic, and that's always good to go.
Dr. Tanya saying, spill the tea, spill the tea, spill the tea.
I forgot to bring my tea, but I'm gonna spill it anyway because so like I said, hypoallergenic makeup, cosmetics, less is better if you can do that. But if you
Mhm.
you really don't have no control over that. I always tell people, if you have on makeup, make sure you take it off before you go to sleep at night. And it's funny, like when I'm in my clinic and I see people with a lot of makeup, I can see the makeup wave in their tear film where it's just all brown and dust particles and
What?
stuff. I'm just like,
Okay, so what she wants to know, and
yes, take your
the
own
ladies want to
brushes if
know.
you can.
Thank you.
If
Okay,
you
so you can
can bring
see.
your own
So,
makeup, your own brushes and stuff, and you don't like, people come in there with their little tool belt, cosmetic brushes and stuff. You don't know where they been, who they been on,
yeah,
what they been doing.
yes.
Just like, oh, what do you usually use for your makeup session? Because I can get that and I can have my personal stuff and you could just use that personal stuff that I get just for my eyes. Because with brush, a lot of times, what I see is when people use brushes, they can cause abrasion. They can cause abrasion on the skin that can get infected, by putting those brushes around the eyes.
Mm-hmm.
They can get irritation from all that cosmetic that's kind of swimming around their tear film,
Yeah.
and which can cause like a conjunctivitis. Usually, it's more like allergic conjunctivitis. So, but a good thing is if you do have a lot of eye makeup, try to carry some artificial tears. Just to make sure the tears are recycled around your eye. So if some makeup does get in your tear film, you can put some tears in there to just to kind of, make sure the tears cycle around the eye and make sure it gets that cosmetic debris out the surface of the eye.
Okay. Awesome. And I
I
can't
hope I
believe
answered the
you said,
question. Oh, I got
yeah,
another
that's,
one, which is lashes. When you get those lashes applicated, go to a professional. Okay, go to a professional that does it, all the time. But do not use super glue around your eye. Okay,
who does that?
trust me. I've seen
Really?
it. I've
Really?
seen it. The good thing is super glue is not uh let's say toxic to the eye. It's just,
Oh,
as soon as it hits the eye, it polymerizes and usually it'll, sew the eye shut. So people,
yeah.
and it's hard to get people eyes open, and trying to get people eyes open usually can result in an abrasion. And so, stay away from super glue. Get a
Oh my
professional.
gosh.
Don't do it by yourself. Pay the money.
Right.
Get it done. Hey,
Super glue. Like, I'm sorry. I'm sorry. Because, I mean, I've been in the ER now for almost 20 years and I've not seen anyone use super glue to keep lashes on. Are you seriously saying people? Okay. And okay, and so watch because I'm saying I haven't seen it, watch, I'm gonna see it this weekend. So what do we
jinx yourself.
use, right? What do we use to whatever reverse the super glue? Um
Prayer. Prayer
Please, I'm
and
praying that you got more than I'm praying that you got more than prayer to
what I
offer
mean
as
is
a solution.
what we usually do when the person came in for us. We just had to use some, try to use some warm compresses, some baby shampoo to try to kind of dissolve that soap, because once it locks
Hmm.
down, it's like, cell block four. This is like you may not get the eye open for a good 24 hours. uh,
So can I
Sometimes I think
safely,
once
so
it,
I can safely discharge somebody from the ER like that, after
nah,
I try a few things, yeah.
nah, you
I
probably
mean, we
should
got
call in the
uniform, we
big
got
guns.
petroleum
You
jelly.
probably should call in the
Okay.
ophthalmologist for that.
But this stuff happens on Saturday night. It only happens on Saturday night
Well, I
when you're
mean,
not in the office.
well, I say this. I mean, if the patient is just like hysterical about getting their eye opening and stuff like that, you may have to call in a big gun. But like I said, the super glue is not toxic to the eye, so you just
Uh-huh.
in some kind of way you can console the patient, like, hey, don't worry, use some warm compresses, baby shampoo, liberally on the eye, and eventually it will come open.
Mhm.
It just had, and I mean, use some traction on the eye, and just say, hey, you sewed your eye shut. You may have a skin scrape. You may have an abrasion,
Mhm.
and that needs to be followed up on. It's just the price you pay for beauty.
So, ointments like bacitracin, don't use that, or
I mean, you
you
can
think?
use ointments. I usually use erythromycin ointment if they don't have an allergy,
Okay, try that.
bacitracin. But I mean, the key thing, people just ain't gonna be satisfied till they get their eye open, you know.
Right, right.
And so, I mean, it's a challenge. It's a challenge. I mean, it's man versus chemical engineering. I
Hmm.
mean, it can be bad. I've seen it
Definitely.
bad.
Well, I'm glad we talked about that because I'm gonna see that now. I'm sure of it. So Okay, so guys, so I'm
Get
Dr.
your Will's
Kadisha.
eye manual
We've been
book.
talking. Okay, I think I have one too, and I'm not letting you go yet. I'm just, since we've been talking for a while and it's been really good, we've got quite a few viewers in here. I've not seen this many viewers for a while, so or for many people's live streams, but um, so yeah, so this is Dr. Kadisha. I'm with Dr. Larry, board certified ophthalmologist. I'm a board certified emergency medicine physician, and we are having that, specialist to specialist discussion. ER doctors are resuscitation specialists. We're not eye specialists. And this is Eye Safety Month according to healthfinder.gov. So that's what we're talking about, eye prevention and like eye care. So we've talked about corneal abrasions. We've talked about conjunctivitis. We've talked about foreign bodies in the eye. We've talked about makeup in the eye. Gosh, what else have we've talked about? But so those are the more common things. And so
So, well, I brought up a topic for the ER people, and usually it's the patient that comes in with severe vision loss that
yes,
comes
the
into
worst
the
case scenario.
ER, or if you are a person who, if you were sitting at home, you were chilling, watching TV in a recliner, then all of a sudden the lights go out in one of your eyes. That
Oh
is
boy.
usually a acute event, okay? And that is definitely
Mhm.
something you want to go to the ER to get checked out, okay? If you have vision loss in one eye. And typically with it's usually three possibilities, if you didn't have trauma. It could be you have a vein occlusion, you have a bleed in the eye, or you have a possible retinal detachment going on. And this is
Okay.
severe vision loss. I mean, it can be other, rare things if you have a lot of comorbidities, but if you pretty healthy individual and things have been on the up and up and this just happens, that's what it sometimes can be. uh, as a patient, you just want to get to a emergency room, or don't go to urgent care, or like the people up the street. They not gonna want to know what to do, and they gonna probably send you to the ER. If you can get to an ER that's possibly connected to a academic center, then you can get treated appropriately, because what that's usually going to involve, you're going to need not only ophthalmologist specialist, but also a subspecialist, especially if you're experiencing a retinal detachment. The retinal ophthalmology specialists are the ones that do surgery to correct it. Now, as a ER doctor, if a patient has a severe loss of vision, and usually it's kind of like there's a time window, 90 minutes. If you don't see a patient within 90 minutes and they have like a central retinal artery occlusion, you know, it's not much you can do. And
Okay.
even if they get there before the 90 minutes, it's still not much you can do. because
I hate that.
because it's just an event that happens. And at most, if you are sort of uh, more expert in eye stuff, what you can do if it's a central artery occlusion is to kind of do it like a little massage. It's like kind of punching their eye, but you kind of do a little massage like that, really press on it, and then let it
Hmm.
go. That
Is
in
that
this
to dislodge the clot or
right, to
something?
try to dislodge it,
Hmm.
and that can possibly help out with the final vision outcome. But it's studies out there that say you can do that, and people still might not get their vision back. But
Okay.
you really don't know until you look into the eye and see what you're dealing with. But that's one thing if it's a central retinal artery occlusion. But if it's a, let's say, retinal detachment and it's diagnosed as a retinal detachment, uh, these are some things that probably if you can get a hold of an ophthalmologist, it'd be better to try to get a game plan together, to them come look at the eye, see what's going on.
Mm-hmm.
And then, usually the patient can go home that night, you know,
Okay.
because retinal detachments is not like, oh God, it's retinal detachment, they need to go to surgery that night. Those are surgeries that can be planned, and usually they need to be repaired within 72 hours, depending on what kind of retinal detachment it is. But these things can be a planned surgery and they don't need to be done that night. And
Okay.
venous occlusions and stuff, those are things that's just going to require workups and treatments, long treatment plans, and you're not going to be able to treat that patient
Outpatient.
outpatient.
So outpatient. Okay,
Yeah,
meaning people that we can discharge you from the ER and then you can follow up with the eye specialist,
right.
what, preferably the next day?
Yeah.
Okay. And then Dr. Tanya wants to talk about, I guess, so we're going back to the safe sex. Can we talk about,
I knew Tanya wanted to
well,
see that.
hey, well, well, STDs in the eye, that is real. That is a real thing,
Yeah.
so, and I know, when I've seen plenty of
Clap
people who
on.
thought they had strep
Clap
throat
off.
and it was chlamydia, right? And they got chlamydia of the throat, they thought it was strep throat. They got gonorrhea of the throat, they thought it was strep throat. And, sometimes it is what it is. It's an STD in the throat, or it could be an STD of the eye. So, yes, if you could please, yeah, great questions, Dr. Tanya. If you could please, Dr. Larry, drop some science on STDs of the eyes.
Okay. So
How often do we mistake it for conjunctivitis?
I mean,
Just regular
that's one of
conjunctivitis.
the conjunctivitis differential you can gotta have on adult who has signs that look like it could be pink eye, but it may be a chlamydia trachomatis. uh,
Mm-hmm.
I can tell you about this case I had. It was actually at the when I was on rotation as a resident at the Naval Academy. A patient came in, and sometimes these things are very sensitive. Okay,
Mm-hmm.
and she was having pink eye, and she was just like, "I've done everything, and it just doesn't seem to go away. Um,
Right.
I don't know what's going on." And so when we did an eye exam, and what usually indicates that hey, it may be something more is when you look at the conjunctiva and you have these things called follicles. And follicles are just kind of like an immune response for the conjunctiva to where it's
Okay.
not necessarily allergic, but it may be something viral or bacterial, and it's very robust. And we usually do a little swab to rule it out. It's just like, let me do this swab because it looks like it could be it just for cover our bases. And lo and behold, it was it was chlamydia, and she was married, and she wasn't doing anything bad, and so I mean, it was just an awkward conversation. I was with my
Yeah.
attending, and it was just like, yeah, you have chlamydia conjunctivitis. The good thing is we can treat it with antibiotics, and you'd be good as new. But some kind of way you got to find out who else has chlamydia that you kind of been involved with.
Mm-hmm.
And like I said,
Like,
she was married, and yeah.
okay, did this woman know R. Kelly? Because that happened to somebody. Some R. Kelly gave somebody's wife chlamydia. So
She wouldn't.
that makes
I don't think this was before R. Kelly and the surviving R. Kelly stuff. So I don't think.
Yeah, he gave somebody's wife chlamydia before that documentary came out. So yeah, so folks get so yeah, just something to
T,
remember.
time you wanted
Yeah,
T. There go the T.
say that again.
I said,
Well,
time
yeah, that's
Dr.
right.
Lowe wanted the tea. There go the tea.
Right?
Hot piping hot tea for Dr. Lowe. But
Piping hot. Now, and I have to say, as a person who was born in the Mid-Atlantic area, kind of up north, who started practicing up north and then moved down south to practice, I do notice that there is some reluctancy, more reluctancy to talk about those kinds of things amongst people of the South. I know Southerners are genteel, you're discreet, you're not as uh, whatever, as abrasive or straightforward or even as vulgar as, some of the Yankees can be, but that can help sometimes. I remember practicing in Philly and the person was like, okay, I was doing this with so and so. We did this, we did that, and then I got this coming out of this. But in the South, it's like, no, and then it makes it harder to diagnose. It makes it harder to diagnose things when you're not as open to talking about adult situations. You got to be open with what your sexual practices are, because I know it's not as genteel or whatever, but you got to talk about it to get things diagnosed. So I'm glad you mentioned you brought up that question, Dr. Tanya, and I'm glad, Dr. Larry, you could talk about that. Okay, so all right, so we've talked about central retinal vein occlusion,
central
central
retinal
retinal.
artery occlusion, central retinal vein
Mhm,
occlusion,
mhm,
branch retinal vein occlusion, all the vein occlusions, arterial occlusions, you're going to need to see an eye doctor. Retinal detachments, you're going to need to see an eye doctor. And if you do have a retinal detachment, then more than likely you may need surgery, you know, and you are going to need to see a retinal specialist, which is a subspecialist of ophthalmology. I am a
mhm,
comprehensive ophthalmology. So I basically I did 4 years of college, 4 years of med school, and 4 years of residency. I did not sub specialize into the different specialties of ophthalmology, but my specialty is just seeing everyday people with everyday problems. Eye injury prevention is what I do, and also I'm a cataract surgeon, so I do some refractive surgery,
mhm,
but mostly cataract surgery. Um, but they are specialists like glaucoma, corneal refractive
mhm,
surgeons, retinal specialists,
mhm.
pediatric specialists, oculoplastic, neuro-ophthalmologists, things people kind of go into these subspecialties that deal a lot with, what we call zebras. That's what they love, that's what they do, and they also have additional training in doing specialized surgery such as retinal detachment repair.
Okay, gotcha. Yeah, and shout out to Dr. Charlotte, who is a board certified pediatric ophthalmologist.
Coding specialist. I'm a coding captain.
And okay, yeah. And yeah, ER folks, I mean, we're just told, to chart up to level 5. We don't deal with billing as much. And let's see, we have another question about diabetes and vision.
Okay.
That's big, right?
I don't think we have enough time for that, but I mean, as a primary care doctor or
Mm-hmm.
any kind of doctor, if you have a patient with diabetes, make sure they get their yearly dilated. That means they have to go get drops in their eyes, get their pupils open, dilated eye
Mm-hmm.
exam. So to yearly dilated eye exam to be screened for any diabetic changes to their eye. Typically,
Yes.
people who are well controlled with their sugars and stuff, they usually don't have any problems. But people who are type 1 diabetic or had diabetes for
Mm-hmm.
over 10 years, eventually you will
Mm.
show some signs of diabetic retinopathy. And that's important
Got it.
for your primary care doctor to know if you start have the signs of diabetic retinopathy, because they need to probably get better control of your blood sugars, or we as ophthalmologists need to do more treatment procedures on our end to make sure that you don't have significant severe sequelae from diabetic retinopathy. Diabetic retinopathy, severe diabetic retinopathy can result in vision loss, irreversible vision
Gotcha.
loss, blindness.
Irreversible.
So make
Mm.
sure, stay on top of your blood sugars, stay on top of your diabetic medications, and get your eyes checked every year. Now, the screening
Gotcha.
goes, if you're type 1 diabetic and you're diagnosed, you don't need an eye exam for 5 years after diagnosis. Usually, type 1 diabetics are young. So, if you're first diagnosed with diabetes, you need to get an exam within 5 years or around 5 years. If you're type 2
Okay.
diabetic, you as soon as you get diagnosed, you need a baseline eye exam, dilated fundus exam. So, if you're type 2, as soon as you get diagnosed, you need to be seeing an eye doctor for exam.
Mm. Mm. Mm-hmm. And is it true that if your blood sugar is elevated, that can cause blurry vision?
Yep.
Can you have blurry vision?
Yes. If
So
you
that,
if your
hmm
blood sugars is consistently in the twos or threes or above, or your HbA1c is over 10, then it can cause visual changes. And usually, you need to get your eyes checked, and you need to get the sugars under control. But a lot of times, when people have this blurry vision, they'll think, "Oh, I need to get some glasses because my vision is changing." But
mm.
no, your vision's not changing. It's just your blood sugars are not under control. So we tell people who come in, if their blood sugars are high or their A1C is high, hey, let's get this down. Let's get it under control. I know we
And so then their
check.
vision could their vision clear up in that case? Like if it's, if it's just a
It
matter
can
of,
fluctuate.
okay,
It can change. It can go back to where it used to be, where they don't need
okay,
glasses, or if
mm-hmm,
it's really something where they need glasses, want to get those blood sugars under control, and then when they come back in the next 3 to 4 months from follow up eye exam, if the blood sugar is under control and the A1C is going back, getting getting back control, then we can dispense some glasses to help them if they really have a problem.
okay. Got it. And we do have Dr. Charlotte, the board certified pediatric ophthalmologist
Dr.
in the
Charlotte,
building. Her ears must have been itching for ears because we just gave you a shout out, Dr. Charlotte. Oh my gosh. Yes, he
I'm
is
trying to
Dr.
be like you.
Knowledge.
I'm sending your safety glasses this weekend.
Awesome. So, oh my gosh. So we've been on here for over an hour. This is amazing. And then the viewership just went up. Like somebody else. I don't want to keep you all night. But so, folks, maybe just one more question or concern. Before we end for the night. If someone has a burning question, gosh, another someone else just joined. So, another just one for that. Oh, let me, Dr. Larry. What's the difference between what an optometrist can do and what an ophthalmologist can do? Need to know. Okay, Dr. Larry, did we drop off here? Let's see. Where are you, Dr. Larry?
Yeah, and Dr. Larry does have a book. Dr. Larry does have a book. So yeah, once he comes back on, then we will. Yeah, then we'll ask him about his book. Okay, so folks, so tonight this was a very, Dr. Larry is a comprehensive ophthalmologist, and we had a comprehensive discussion of eye care and eye safety. Do check the replay. Do share this. Share this with your non-doctor friends, especially. Just because you can see okay doesn't mean that everything is okay. Your eyes are among your most important organs. They need to be checked, even if you feel fine. You feel that your vision is okay. I would, at least get your eyes checked, once a year, just to make sure that everything still is okay. I'll share a personal experience. I was getting, my annual eye exam, and the optometrist couldn't see the edge of my retina, and she feared that I had like a small retinal detachment. Hopefully Dr. Larry will come on back. And so they referred me. Let's see. Now, Dr. Larry, I got to figure out how to bring you back on. Let's see. Let's see how to on a personal page. Let's see. Okay, so Patrick, thanks for coming back. Let me see. Let me try to bring Dr. Larry back on. Okay, so Dr. Larry asked to be brought on camera. So then I can add you back to the live. Okay, other folks are asking to be brought on to the live, so I think you can also. Oh, thanks, Patrick. Thanks for bringing friends into the watch party. Well, let me see if I can get Dr. Larry back on here. Let's see. Are you able to hit that option, Dr. Larry, to ask to be brought back on camera? Let's see here. Okay, you should have the option to ask to be brought on camera. Okay, there we go. Okay, Dr. Larry is coming back.
All right. Sorry.
Oh, that's okay. Yeah, thanks for coming. Get you back.
Sorry, guys. See, I had my headphones in, and I didn't know my phone was dying. I had to get my power cord. Classic mogul no.
All right. I'm getting some reverb. Are you able to? Let me see. Are we on multiple things?
Say that again.
Are you on more than one? Do you have more than one device connected to the live?
I just turned my other one off. I was on my computer, but I just exit out of it.
Okay. All right, and then
Is it?
okay, so Patrick just started a watch party. He is the husband of like my best friend up in Maryland, and he said a bunch of his friends joined. So, Dr. Larry, how much time do you have to give us?
Oh, it's 10:20.
Say that again.
10 more minutes. 10 more minutes. I gotta get to bed. Sorry. 10 more minutes.
Okay. Okay, so folks, if you have like a burning question or a comment, now is the time to offer that. Let's see. Oh, so what about hypertension and IQ? Because I speak on that, please.
Hypertension and diabetes go kind of like hand in hand. If somebody has high blood pressure and does not have diabetes, instead of every year, they should be checked every 2 years biannually if they don't have diabetes. A lot of times people who have high blood pressure have diabetes, so they need to be checked every year. But if you just have high blood pressure, of course, you want to keep it well controlled, and there can be, people can have hypertensive changes to the eye, especially if you have high blood pressure, really high, for acute event. You know, it can cause what we call papilledema. It can cause hemorrhages on the retina, cotton wool spots on the retina, which are small little infarcts on the retina. So you always want to make sure you keep that blood pressure under control. But people with chronic high blood pressure problems, they usually have more, well, it usually causes more narrowing of the arterial vessels in the retina. And if those arterial vessels narrow, and with narrowing, they become hardened, they can cause what we call a branch retinal vein occlusion. People who are at more risk of getting a branch retinal vein occlusion who have long-standing uncontrolled high blood pressure.
Got it. And is there anything like glaucoma or no?
There is a connection with glaucoma. People who have uncontrolled glaucoma, that means if their eye pressures are constantly running high, they are more at risk of developing what we call a central retinal vein occlusion. And they can have a branch retinal vein occlusion, but more so people who have long-standing glaucoma, high pressures in the eye, they can end up with central retinal vein occlusions. Now, there are different types of glaucoma out there, and a lot of times what people in the emergency room come across is acute angle closure glaucoma. And that's basically the eye is a very compact organ. You know, there's this very small, very compact, and the eye produces its own fluid, and it has its own way it drains the fluid and produces its own fluid. If that fluid is blocked from being drained, or is there cutoff of the fluid in the eye getting to its regular drainage system, then you can have what we call acute angle closure glaucoma. Typically, the closure event can be managed with drops. That's usually drops to control the eye pressure. But typically it can be controlled with drops, but rarely people may need like IV medicine, and sometimes they may need to be taken to surgery, or need to be seen by ophthalmologists to do what we call laser procedure to help break that acute pressure spike from the acute angle glaucoma.
And I know he has the Oh, go ahead.
I was saying acute angle closure glaucoma. The reason why it's called acute angle closure, that angle where the fluid drains out of is closed off. Fluid has nowhere to go. So it just builds up pressure in the eye. So that's why we call it angle closure. there's a blockage of the drainage system of the eye that, you know, the eye can't, so the pressure increases and uses the pressure. When the pressure goes up, you can have pain, you can have change of vision, you can have halos in your vision. There's like little white circles in your vision that weren't there before.
Got it.
Got it.
So
So
one
one last question,
Larry.
Dr. Larry.
The difference
The
between an
difference between an
optometrist and an
optometrist and an
ophthalmologist before
ophthalmologist
we
before we
finish for the night.
finish for the night. Um, uh, Ophthalmologists, we are MDs. So basically, we go through 4 years of college, 4 years of medical school, and 4 years of training, and then 1 to 2 years, or maybe sometimes 3 years of subspecialty training. Like I said before, it's either glaucoma, retina, cornea, refractive surgery, neuroophthalmology, oculoplastics, different types of subspecialty that's, a couple years or a year or two after residency training. So the another difference between optometrists and ophthalmologists, we do surgery. We do laser surgery, we do LASIK, we do cataract surgery, we do glaucoma surgery, we repair retinal detachments. Optometrists, they usually go through 4 years of college and 3 or 4 years of optometry school, and then they go out, and they start their business or they work for somebody. And mainly, they don't do surgery. There are some optometrists that can prescribe drops, but it's limited. Uh, but they don't do any procedures. They mostly dispense glasses, fit people for contact lenses. They do special contact lens fitting, which, they're great at that. And sometimes I refer to optometrists for that. But they typically are limited in what they can prescribe, and they typically don't do medical procedures or surgery. They shouldn't be doing it.
Got it.
Got it.
So yeah, I
So, yeah, I
apologize for the
apologize for
feedback,
the
you guys.
feedback, you guys. Dr. Khadijah.
Huh?
I'm an ophthalmologist, Dr. Khadijah.
Right. And yes, I know that you're a board certified ophthalmologist, Dr. Larry, and especially because I was so happy to have you tonight. I'm sorry about the
I'm sorry about
feedback,
the
guys.
feedback, guys. Oh, I get a lot of feedback.
Yeah,
I'm not sure why.
But I want to thank you so much for taking all this time. I mean, we were on here for an hour and it's 10:30. But you are really appreciated here because I mean, we had high viewership during our discussion, a lot of feedback, comments, and questions. Someone even suggested a part two discussion. So that's how popular you are. We still have, we had a drop in viewers and then more viewers just during the discussions in the last couple of minutes. But I know you have to get. So final messages. Okay, that's one thing right there. So the parting statements, Dr. Larry. Oh, tell us about your book. Dr. Dietrich says, tell us about your book and where we can get that book.
Oh yeah, I do have a book. I can send you the link. It's called All Eyes by me, Dr. Larry Ferdinand. It basically sums up everything that we talked about tonight. Tells you what you need to do, gives you some nutrition facts, tells you about diabetes and eyes, cosmetics, looking at screens for a long time. Also, if you have kids, when it's a good time to get your kids screened for eye exams. I mean, there's a whole bunch of stuff in there. Things that you can easily reference is an easy read, so you can have this knowledge whenever you go anywhere. Hey, thanks, Dr. Charlotte. Hey, they're coming. I'm sending them to you, Dr. Charlotte. Sending them.
Is this your new product? Is this an invention or product that you're coming out with, Dr. Larry?
These are designed by me. These are designed by a board certified ophthalmologist. These are safety glasses that you can wear around the house when you're doing work. When you are at the job site, you can wear these. It has the side protection, so it gives you more protection around your eyes against the debris that's out there. So I will also put that link. We doing pre-order right now for these glasses, the safety glasses. We have a black pair and also have a pink pair for the ladies out there in honor of Breast Cancer Month.
Awesome. Awesome. So you said the website is coming?
Yeah, I'm going to send it to you so you can put it with the video.
Okay, fantastic, Dr. Larry. Absolutely fantastic. I didn't even know. I just asked you to come on because of your expertise. I didn't know that you had a product also. Dr. Larry, he's so modest. I had no idea. So we've got a book, we've got glasses.
I know you don't be checking for me.
Huh?
I know you don't be checking for me, but that's okay.
So it sounds like we definitely need to have you back. And yeah, definitely let me know of some other things that we might have missed, Dr. Larry, like things that you want to discuss. I thank you so much for coming. We really, really thank you for coming. We had such a great turnout tonight. So, and thank you for those final, oh, yeah, I was asking about the comments, the final comments, and then you mentioned the glasses. So, some things like the last two things you want to tell people before we sign off.
Last things, don't be afraid of the eye doctor. If you have a problem and you're not certain about it, and you're not feeling like you're comfortable with the answers you're getting, see an ophthalmologist. You can Google it. There's a lot of ophthalmologists in the area. Like me, I'm in Covington, Louisiana, for people who are in this area. Right now I'm with Ochsner Health System. So, you just go online, you can schedule an appointment. It's very easy. And two, don't take your vision for granted. Things can happen. And I always say it's not a problem until it's a problem. It means people don't think about what they're doing or when they're doing it until boom, it happens. And then you got to figure it out. So it's preventative. What this month is, preventative eye injury month. You want to prevent eye injury as much as possible. And it's so easy. It's wearing safety glasses, some kind of protection around your eyes that can really save you time and money and just worry, because it's so many patients out there that say, hey, take away my arm, take away my leg, but please don't take away my eyes. I gotta see, and if it's that important to you, then you can make that investment.
Well said, Dr. Larry. Thank you so much. I know you guys enjoyed Dr. Larry. Thank you so much, Dr. Larry. I really appreciate it. Hopefully we can have you back to discuss some other eye topics. And I am Dr. Tanisha, your board certified emergency medicine physician and author of the book, Robust Health in the Emergency Room by Dr. Larry. And my book signing is Thursday, October 17th from 5 to 8 in Houston, Texas at the Melodrama Heat. Please continue to comment with questions, concerns, anything as far as so that maybe we can bring Dr. Larry back to more discussion. And Dr. Larry, what is your call to action? Where can folks find you on social media?
Dr. Larry IMD, social media handles, all of them, Facebook, LinkedIn, Twitter. I always usually put up weekly posts. Facebook page, Dr. Larry IMD. Try to get as much content to you guys as I possibly can, but make sure you like my Facebook page and follow me on IG and Twitter.
Awesome. And follow me, you guys, Dr. Khadijah MD on Instagram, Facebook, and Twitter. That's DrKhadishamd. And we wish you guys a good night. Thank you again, Dr. Larry. We will talk soon.
Good night.
Bye, guys.